A very good afternoon to all of you. Today's lecture would be on immunologic and drug-induced diseases. I'm Dr. Lahari here from Department of Oral Medicine and Radiology. So this chapter actually the topic itself, I have tried to include a couple of topics into this. Notice the learning outcomes, it says list at least 5 autoimmune diseases and affecting the oral and maxillofacial region and their oral manifestations. Describe in brief clinical features and management of lupus, scleroderma and rheumatoid arthritis. So lupus we've already covered in under red and white lesions. And identify clinical manifestations of allergic conditions, drug-induced disorders, and very brief about angioedema, Lichenoid reactions, and graft versus host disease. So it's a combination of quite a few chapters actually, right? So let's look at what immunity means. First of all, it's protection against disease and the ability of the body to identify self versus non-self or foreign. Immune responses could be innate or acquired. Again, the innate immunity could be non-specific or immediate response, and acquired could be highly specific and can take several days to develop. So if you look at this flow chart here, you will see that immunity is either innate or acquired. Innate is inborn due to genetic factors. The acquired is divided as active and passive. Active is due to one's own antibodies, which could be the natural. When you get exposed to infectious agents, the body develops own antibodies and develops immunity to it, or artificial, which you get through immunization. Passive immunity is when you receive ready-made antibodies, which could be natural from maternal antibodies or artificial, again from other sources such as vaccines. When you're talking about the oral defenses, homeostasis is one word you must understand. It is a balance. Homeostasis is actually a balance in the oral cavity, which is maintained by innate and acquired immunity, and the components which help in achieving this homeostasis are primarily saliva, salivary innate antimicrobial proteins, gingival clavicular fluid, transurating plasma proteins, circulating WBCs, oral mucosal keratinocyte products, and proteins from microbial flora. That's some of the good bacteria which we're talking about. Whereas on the other hand, immune deficiency would be the opposite of immunity. It's an individual, a person who's immune deficient is an individual who's not capable of mounting a normal immune response. So these could be because of hereditary causes, secondary to infections, example is HIV, secondary to major diseases like cancer, diabetes or alcoholism, and transplants. That means when the person receives an organ or a hematopoietic stem cell transplant, the body goes into a state of immune deficiency. On the other hand, autoimmune is a word used for disorders in which there is evidence of an immune response against one's own self. So lymphocytic infiltration is seen in target organs. Examples would be SLE, scleroderma, idiopathic inflammatory myopathies, rheumatoid arthritis, and mixed connective tissue disorders. So we won't be going into the entire details of all of this. We'll just look at them, a few of these. So let's look at scleroderma first. It's already been spoken to you about in oral pathology, but let me give you another aspect to scleroderma here. Scleroderma means hard skin. There is unregulated collagen deposition, which is the hallmark of the disease. It could be the progressive systemic sclerosis, which is more generalized and diffused. Again, it has types, which is limited and diffuse. One of them is a Crest syndrome. Or it could be localized scleroderma, which is either in the form of linear scleroderma or morphia. Clinical features include rapid thickening, visceral organ involvement, and other organs are involved. And of course, Raynaud's phenomenon. The fingertips, if you can see in this radiograph, are resorbed, and that happens because of Raynaud's phenomenon, where the extremities turn blue due to lack of blood supply. This is an example of a case with mask-like appearance. Please make note of the beak-shaped nose and the mouth looks pursed and the aperture looks smaller. So on the other hand, localized scleroderma involves primarily only skin with minimal systemic manifestations, and it rarely progresses to the systemic one. It could be linear scleroderma, which looks like a sword cut, where you can see specific area of the face here having a defect in the skin, or it could be morphia, where a larger area is involved. Oral manifestation of scleroderma, what is important as dentists to notice and to manage is that the lips become rigid, oral aperture narrows, giving an appearance of purse string appearance. Skin folds are lost, giving a mask-like appearance like we saw in the previous picture. Tongue becomes hard and rigid, and speaking and swallowing become difficult. So imagine the plight of these patients that progressively the disease is becoming worse over the months and years, and a patient finds it difficult even to speak and swallow, and treatment is only very limited. This is happening because, like we told you in the previous slide, that there is excessive amount of collagen deposition. Patient has dysphagia and xerostomia, which could be again secondary to Sjogren's. Remember, we could have overlap of autoimmune diseases. Oral telangiectasias on the lips and hard palate, like spider-like appearance of the blood vessel. On radiograph, periodontal membrane thickening can be seen, which is generalized. You'll see in these radiographs here, generalized widening of PDL, but it doesn't mean that these teeth have got some problem in the pulp. It's just because there's excessive amount of collagen deposited in the PDL. So mandibular resorption of the angle condyles due to fibrosis of muscles can happen, and calcinosis of soft tissues can take place. So the diagnosis involves diagnosis of anti-nuclear antibodies, and there is definitely anemia, elevated ESR, and hypergamma-globulinemia. The management involves calcium channel blockers, depenicillamine, and cyclophosphamide. Dental management of these patients should be revolving around trying to maintain oral hygiene, and with the limited mouth opening, we could suggest patients stretching exercises, but only very minimal improvement is generally seen. So since there is difficulty in brushing the oral cavity, brushing the teeth effectively, use of fluorides is important, and pathologic fractures of the jaw have been noticed, and hence that's another important area that needs to be managed. Moving on to rheumatoid arthritis, it's a common autoimmune disease. There is systemic inflammation of arthritis of small and large joints. Treatment can, of what is of importance as a dentist is that the treatment of rheumatoid arthritis, patients are generally on long-term use of medication, and these oral manifestations can arise because of long-term use of these. For example, methotrexate, which is a common first-line treatment which is given in rheumatoid arthritis cases. Also, these patients are generally on steroids, and with steroids come opportunistic infections. Dental management of patients on rheumatoid arthritis, what is it that you need to keep in mind is their drug regimen, what the patient is following, and hence modify the treatment based on the drug interactions as well as adverse reactions that could happen. Complete blood counts need to be monitored prior to any invasive dental procedure, and also generally late morning appointments are better because patients tend to have stiffer joints or awakening in the mornings. As an example of someone with rheumatoid arthritis, you will see a lot of nodes here on the arms, on fingers, and this is visible even in the radiograph. Other diseases which are medication or drug induced could be xerostomia, swellings in the oral cavity or in and around perioral region, pigmentation, gingival enlargement, and oral lichenoid reactions, which could be non-specific ulcerations or mucositis, vesiculobullous-like lesions, like for example lichen planus-like lesions, erythema multiforme, and pemphigus-like lesions, all of which are induced by medication, and a bisphosphonate-related osteonecrosis of the jaws, which is called as bronch, or medication-related osteonecrosis of the jaws. So let's look at bisphosphonate-related osteonecrosis of jaws, because that is one area which is relatively new to you. This is found in patients who have received IV and oral form of bisphosphonate therapy. Now, bisphosphonate therapy is generally given for various bone related conditions. The most common example is osteoporosis, where the bone becomes more and more porous and the patient is likely to have fracture of the bone easily. So the medication that is given are generally bisphosphonates. Uh, so example of that is zoledronic acid. Patient who is having bisphosphonate related osteonecrosis of the jaws generally has exposed non-vital bone in the maxillofacial region, which is very painful and can lead to swelling as well as fracture of the bone when it is necrotized. How is it caused is generally by trauma. Example of this would be a recent dental extraction and trauma to the dentoalveolar region because of a dental extraction, which have limited capacity for bone healing due to the effect of bisphosphonate therapy. What is meant by that is patient is already on medication which is making the bone susceptible to easy fractures. So when a dental treatment is performed and that area doesn't heal, it ends up giving the area a necrotized region, which is what is called as osteonecrosis. These are examples, case examples of non-vital exposed bone, for example seen here in the third molar region, or even here seen in the maxillary region. Exposed bone, very painful, extremely difficult to heal, time taking, and patient is in extreme distress. This is a patient, of 45-year-old female with a history of breast cancer, and as a result of the treatment of breast cancer, patient would have developed osteoporosis and is on zoledronic acid. And you will notice here that there is a large defect in the bone seen here, which is appearing like a necrotized area. The radiograph, if you look at only the radiograph without the history, you will think of this as a osteomyelitis, and which is fair enough because that is how it appears on the radiograph. So bisphosphonate related osteonecrosis is a typo is actually on radiograph appears very much like osteomyelitis of the jaws. The staging given by American Association of Oral and Maxillofacial Surgeons classifies it into stage 1, 2 and 3. Stage 1 is exposed necrotic bone, patient is still asymptomatic and no evidence of infection of that bone. Stage 2, exposed necrotic bone, symptomatic patient is experiencing pain and there is infection. Stage 3, exposed necrotic bone, symptomatic patient, infection, and one of the following. Either there is a pathologic fracture or oral fistulas or osteolysis leading to inferior border of the mandible. Management involves discontinuity of the treatment, bisphosphonate treatment, which is again with the help of the physician, and no dental treatment, therapy or minimally invasive dental therapy is advised in patients who are on bisphosphonates. So it's important to take the drug history of patients, especially those who are elderly, female, postmenopausal, who have any other underlying diseases. Important to make sure the history of medication or medical history is very clearly taken. So one method of avoiding extractions, for example, is to perform root canal therapy instead of extraction. That is, even if there was a grossly decayed teeth, which is very difficult to actually provide a crown for, even if you actually perform root canal treatment and leave the roots in there, it would serve the purpose of not causing infection. So how do we treat a stage 1 case is with antimicrobial rinses. Chlorhexidine is proven to be very helpful and no surgical intervention. Stage 2, antimicrobial rinses, systemic antibiotics or antifungals may be required along with analgesics. Stage 3, antimicrobial rinses, systemic antibiotics or antifungals, and analgesics as well as surgical debridement or resection of the area. Moving on to lichenoid contact reactions. Like I told you, this chapter is a combination of a lot of drug-induced and immunologic diseases, so you might find them a little unrelated to each other, but at the end of the day, they're all related in some way or the other. So this is a type of delayed hypersensitivity reaction to dental materials and amalgam and composites. So that's why it's called as a contact reaction. The oral manifestation is generally confined to sites in contact with the dental material. is usually the buccal mucosa or the border of the tongue, which is in contact with a restoration or a dental material. Rarely symptomatic. The clinical features are very similar to oral lichen planus, and it's very difficult to differentiate. The only method of differentiating is to actually replace that restoration and wait and see. Now, when we replace it and wait with another suitable restorative material, it might even take about 2 to 3 months for the lesion to subside. Even on histopathology, oral lichen planus and lichenoid contact reactions appear similar with similar lymphocytic infiltration, so it will be very difficult to actually differentiate them clinically and histopathologically. The only differences, like we've mentioned already, are first of all, most of the times oral lichen planus is bilateral, and lichenoid reactions or contact reactions should subside after the causative agent is replaced. This is the case of lichenoid reaction to amalgam, where you see that the amalgam which is there in these restorations is actually causing an erythematous area along with few white striae in the periphery, and after the restoration has been replaced with composite, the lesion subsides. So that's the best example to show you that lichenoid reaction can happen, contact reactions can happen to with amalgam. This is another case of a replacement of a PFM bridge. This is a 35-year-old male patient with erythema around the PFM bridge. You can even see a few ulcers here, which have subsided after the porcelain fused to metal bridge has been replaced with an all ceramic FPD or a bridge. So this patient was even positive. He had a positive patch test, probably to the metal that was there in the PFM bridge. When we're talking about contact reactions, it's important also to talk about other medication or substances that can cause allergies. The allergic contact stomatitis, also called as stomatitis verinata, can happen to foods or food additives, even toothpaste, mouthwashes, gloves which the doctor uses in the patient's mouth, rubber dam, candies, all of which contain a lot of flavoring substances. So there is generally erythema, superficial vesicles, and epithelial desquamation, very similar to what we see in either erythema multiforme or some other form of vesiculobullous diseases. Stomatitis medicamentosa, on the other hand, is allergic reaction to systemically administered drugs. So again, this is anaphylactic stomatitis. That means an allergic reaction. You swallow a pill and you end up having reaction inside the oral cavity. So if this reaction happens every time on the same mucosal surface, then it's called as a fixed drug eruption. So these are some new terms that you will have to remember. But again, at the end of the day, they're all forms of hypersensitivity reactions. So moving on with oral lichenoid reaction, this is an example of not a contact reaction, but reaction to medication which has been swallowed. Something very similar to what was spoken in the previous slide, allergic stomatitis. Right, so we can see here that there is erythema as well as a area which looks like it's going to form an ulcer, and white striae at the periphery of the lesion. So this should subside after the medication is withdrawn. So that is what is the hallmark of a lichenoid reaction. Moving on to transplantation and oral health consideration. Now this I have taken from another chapter, but I thought it should be important to introduce it here because we are already talking about drug-induced diseases. So I thought it should be included as part of it for you to understand this area. Now, transplant medicine is a complex and a difficult area to understand. So let me just give you a brief overview of what is there that is important for you to understand here. First of all, the different types of transplants that are available or done are organ transplant, hemopoietic cell transplants, and the complications that are involved with this could be end organ damage from pre-transplantation conditioning therapy itself, or graft versus host disease, or infections. Now, when you have transplant patients, they may have various oral manifestations because of the transplant itself. Now, it could be in the form of infections. For example, bacterial infections can occur because your body is receiving a something which is foreign and not belonging to the own body. So it could be or not belonging to the area where it's supposed to be, if it's an autologous or an allogenous transplant. Is not classical bacterial infections and which generally prompt antibiotic therapy. There could be increased caries risk, poor periodontal health, gingival overgrowth, for example with the use of cyclosporin. This is an image of a patient who's been put on cyclosporin, and you can see extensive amount of gingival overgrowth. Cyclosporin is an immune suppressive drug. Examples of viral infections like HSV, chronic recurrent intraoral herpes, and multi-drug resistant variant ones. This is an example of oral hairy leukoplakia, which is an Epstein-Barr infection seen in patients who have received a transplant. Similar infections are also seen in immune deficiencies, which is, for example, in HIV. So once the immune deficiency status improves, this should subside also. Fungal infections like Candida, definitely wherever there is opportunity, Candida will appear, pseudomembrane type or ectrophic type, or even deep ulcers like aspergillosis, mucormycosis, blastomycosis, which are generally not common fungal infections and only happen in patients who are having an underlying immune deficiency condition. There could be other non-infectious oral manifestations like malignancies developing as a result of the transplant itself or result of transplant conditioning, pre-transplant conditioning therapy, or post-transplant medication given. For example, lymphomas, Kaposi sarcoma, or even squamous cell carcinoma of the lips. And graft versus host disease, it's a non-infectious oral manifestation or which is seen because the graft is has to be dealt with by the host, and because of this there's a reaction that develops in the oral cavity or elsewhere in the body, which is very similar to oral lichen planus or lichenoid drug reactions. So if you look at only the clinical picture, it may be difficult to make out what the lesion is, but if you know the history that there is a transplant received, then you definitely know that you're looking at graft versus host disease. You have non-gingival soft tissue growths, oral mucositis, salivary gland dysfunction, and development of tooth defects and dentofacial anomalies if the grafts were placed in children. This is an example of graft versus host disease. You will see, look at this example of an non-specific, not in the gingiva, but a growth which is seen on the buccal mucosa. It's very rare for us to see a growth like this in the buccal mucosa. Is generally well defined or well formed, smooth bordered, and bordered, and you will think of it as a fibroma, but this doesn't fit under the category of fibroma, and there's so much of unexplained white and red areas. Or example of this where you're seeing a lot of plaque-like appearance of lichen planus with an ulcer, but if the history of the patient says that he's received a graft or a transplant, then you would know that you're looking at graft versus host disease. So generally these kind of patients are seen by dentists who are hospital based. So the oral health considerations in transplant recipients are pre-transplant and post-transplant. In the pre-transplant phase, it's important, the dentist's role is to rule out acute oral conditions that may affect the transplant. So a dental appointment is generally advised by the transplant surgeon so that any source of infection from the oral cavity can be eliminated before the patient is conditioned to receive a transplant. After the transplant has been placed, of course, the dentist's role is minimal and only restricted to emergency treatment in case of excessive pain or some infection or specific management needs. So when we're looking at oral health consideration, we must understand that all transplant patients would be placed on immune suppressive agents. So, and these agents can cause other drug reactions, they have renal elimination, and also can induce risk of neoplasm. Examples of some of the immune suppressive agents are cyclosporin, tacrolimus, azathioprine, mycophenolate mofetil, and biologics like basiliximab. So this is a chart I've taken from Burkitt's 12th edition, which shows you dental management consideration of pre-transplant consideration and post-transplant consideration. You might want to go through this in details to give you an understanding of how the dentist plays a role in managing these patients. Moving on to hypersensitivity reactions. Now we're already familiar from your pathology, general pathology and oral pathology knowledge about what hypersensitivity reactions are. They could be classified as 1, 2, 3 and 4 for general understanding. 1 is generally immediate anaphylaxis, which could be in the form of an anaphylactic reaction, asthma, hay fever. Cytotoxic is type 2 reactions are generally cytotoxic, which could be examples pemphigus, idiopathic thrombocytopenic purpura. Immune complex reactions are type 3, which could be like rheumatoid arthritis, serum sickness or lupus. And cell mediated or delayed hypersensitivity reactions like contact dermatitis or contact stomatitis, and of course to dental materials, and also graft rejection and their manifestations. Let's look at anaphylaxis, for example. Acute allergic reaction caused by an immediate hypersensitivity reaction, which is mediated by IgE and mast cells. It could be localized, causing urticaria or angioedema, or generalized, which can be in the form of an anaphylactic shock. In dentistry, it could be related to penicillin or muscle relaxant, cephalosporins, sulfonamides, vancomycin, or even radiographic contrast media and vaccines. Of course, again, the last few are more hospital-based examples. This is an example of urticaria where you see large lesions on the skin, erythematous lesions, which could be raised as well. Angioedema is swelling of the face, which can subside after appropriate medication or some time. Could be because of any medication, for example seen in this patient where you have swelling of the lips and the face on one side, and which has subsided after medication has been given. The factors which increase risk of anaphylaxis are history of allergy to other drugs, existing allergies, history of asthma, family history of allergy, which is also called as atopy, and parenteral administration of the drug. So drug that is given systemically is more likely to cause allergy than that is applied topically. And anaphylaxis occurs within seconds of drug administration, or sometimes even after 30 minutes. So that is what is immediate allergy. Now this is an example of latex allergy where you're seeing a lot of red areas and patchy, scaly appearance, probably itchy and painful as well. Now latex allergy is seen in around 10% of the dentists, and that's a big number if you look at this. It can occur as early as second year of glove use itself. That means you don't necessarily have to have a latex allergy as soon as you wear gloves for the first time. The inhalation of glove powder can also lead to symptoms such as asthmatic symptoms. This is a type 1 hypersensitivity reaction, which is contact dermatitis, and you could have cross-reacting agents. Management would be good history taking, use of non-latex gloves, example nitrile gloves, avoid other latex containing products, and of course keep an epinephrine auto injection.